Welcome and thank you for joining us for this Eurofins Biomnis webinar, DPD deficiency testing prior to 5FU-based chemotherapy. The multiparametric approach improves outcomes and reduces overall cost. This webinar is accepted by the Academy for CPD points and also the ACBI, Association of Clinical Biochemists in Ireland, will recognise the 5FU meeting for 1 CPD point. My name is Kirsten Hill and I am the event manager for Biomedica. Please visit the Biomedica website to view the latest information on Biomedica 2020, a virtual festival of medical science, which takes place on the 30th of November to the 4th of December. This webinar will be recorded and uploaded to the Biomedica website. If you have any questions, please put these in the chat box and they will be addressed at the end. And now, over to Jamie and Linda.
Good morning, everybody. Thank you for joining us. My name is Jamie Callahan. I'm with Eurofins Biomnis. So, why do we need to know about DPD deficiency testing in the first place? Well, on the 30th of April this year, the European Medicines Agency issued a press statement stating that they recommend that patients should be tested for the lack of the enzyme dihydropyrimidine dehydrogenase, or DPD, before starting cancer treatment with fluorouracil, given either by injection or infusion, or with the related medicines capecitabine and Tegafur, the oral prodrugs of 5-fluorouracil. So let's look at 5-fluorouracil. So 5-FU and its prodrugs capecitabine and Tegafur are analogues of the pyrimidine bases uracil and thymine. And you can see in figure 1 here on the right that 5-FU is the uracil molecule with the hydrogen on position 5 of the molecule substituted by a fluorine atom. So these drugs are widely used both as monotherapy and as part of a chemotherapy regime in the treatment of a wide variety of solid tumours, which are listed here. However, these drugs carry an up to 20% risk of a severe or very severe toxicity and up to 1% risk of death. And this is due to a deficiency in the activity of the DPD enzyme. The DPD enzyme is coded for by the DPYD gene, and we'll look at that in some detail shortly. So you have here a schematic diagram of the metabolism of 5-FU. So first of all, as mentioned, there are 3 main sources of 5-FU, the oral prodrugs or the infusion of IV 5-FU, native 5-FU. Plasma 5-FU is metabolized by the DPD enzyme here, and up to 80% of the administered dose will be catabolized into inactive intermediates for excretion, and about 15% of the total catabolized will be excreted unaltered in the urine. So only a small fraction, or 20% of the administered dose, is converted into active metabolites, which give rise to its cytotoxic effect. So there are 3 main active metabolites, and the mechanism of action is the inhibition of the enzyme thymidylate synthase, which governs the synthesis of thymine essential in the to DNA, or the diphosphate and triphosphate molecules, which are substituted for the nucleobases in RNA and DNA. And through these 3 mechanisms, 5-FU acts as an anti-cancer agent. But it's important to note here that DPD is the governs the rate limiting step for the metabolism and excretion of 5-FU. So, bearing this in mind, we can tell that DPD deficiency will lead to an increase in plasma 5-FU levels. This can lead to grade 3 and 4 toxicities, which include diarrhea, mucositis, hand-foot syndrome, which is a painful skin problem, myelosuppression, neutropenia, and also increases the risk of death in patients. So that's a DPD deficiency. However, an increase in the DPD activity will lead to decreased plasma 5-FU levels through increased catabolism and excretion. This can lead to underdosing, reduced efficacy of the drug, and obviously poorer patient outcomes. And a high percentage of patients are actually underdosed. Now, DPD displays saturable enzyme activity and nonlinear pharmacokinetics, and therefore there is very significant interpatient variability in DPD activity, which makes the administration of the drug, monitoring of DPD in the administration of the drug, important. So let's look at DPD in a bit more detail. First of all, the enzyme is ubiquitous. Now, because of the reasons just mentioned, its activity is subject to wide interpatient variability, and this results in a possible range of enzymatic deficiencies that span from partial to complete. And figure 3 on the right here shows population distribution of peripheral blood monocyte-based DPD activity in 124 healthy subjects. What it demonstrates is that the DPD activity follows a Gaussian distribution. And what you can see is a wide spread of activity from reduced activity to enhanced activity, with the majority of patients exhibiting normal activity around the middle of the graph. So we've established why it's important to measure DPD activity in a patient who has been prescribed 5-FU. So in routine practice, there are 4 methods available to measure the enzyme activity, and these are genotyping of the DPYD gene, phenotyping, looking at the concentration of uracil alone, or phenotyping, looking at the ratio of dihydrouracil to uracil. So how this works essentially is that the enzyme DPD converts uracil to dihydrouracil prior to excretion. So the greater the enzyme competence or ability, if you like, the higher will be the concentration of dihydrouracil, and therefore the higher the ratio number. Or finally, and what we're going to look at in a little bit of detail, is the multiparametric method, which combines the genotype, phenotype, and epigenetic data. So genotyping is the most studied of all 4 DPD deficiency screening methods. And ODPM, who are the originators of the multiparametric method we're discussing here, analyzed 14 studies, which included over 18,000 patients, 18,500 patients, including a study based in Ireland. So these studies range in date from 2006 to 2019, and this is not exhaustive, I should stress. And the disease types studied included colorectal cancer, breast cancer, both localized and metastatic, head and neck, gastrointestinal, and pancreatic cancers. So based on these studies, it's been established, these and other studies, it's been established that there are, here, by the way, you have the exome map of the DPYD gene on the right. So it's been established that more than 100 single nucleotide polymorphisms, or SNPs, of the DPYD alleles have been reported. But only a minority of these are of interest here. Only a minority of them have a potentially deleterious impact on the DPD enzyme activity. So ODPM, through their studies, established that the following 4 SNPs were identified them as the most often implicated in clinically relevant to DPD deficiency. So, as I said, there are many other SNPs, but not all of these result in an important clinical outcome. Some are common, some are quite rare. But these 4 SNPs are present with sufficient population frequency to make their detection useful via genotyping for the prediction of DPD deficiency. And there is very little evidence to support the use of many of the other variants. So the variants in use are DPYD 7, 13, 2A, and 9B. So let's look at phenotyping using the metabolic index, or dihydrouracil over uracil ratio. So what you see here is that the DPD enzyme is central for the conversion of uracil to dihydrouracil in normal, healthy cells. And this reflects or predicts indeed the conversion of the drug 5-FU to its metabolite dihydro-5-FU. And therefore, the ratio of dihydrouracil to uracil is a useful measure of DPD's activity. So Kaptein published earlier this year in Dose Response an analysis of the 4 major methods. So let's look at his findings, or the findings of the study on the dihydrouracil to uracil ratio method. So the scoring system employed here is that a ratio over 6 indicates that the patient is non-DPD enzyme deficient. A ratio between 2 and 6 indicates that the patient has partial enzyme deficiency and a reduced dose should be considered. Or a ratio less than 2 indicates that the patient is totally DPD enzyme deficient and that 5-FU is contraindicated. So, if we look at the scores here for the different toxicities, looking at the different score rates, some important numbers jump out. First of all, 13.5% of patients who had a ratio of 6 and therefore were predicted to have normal DPD activity, 13.5% of these patients suffered a severe or very severe toxicity, and 1.5% of patients died. So it's been demonstrated that genotyping alone could not explain all cases of clinical DPD deficiency. This is thought to be due to epigenetic effects in play that are not detected by genotyping alone. And in screening for severe to very severe toxicities, it was demonstrated that genotyping alone resulted in almost 60% false negatives, leading to large numbers of severe toxicities and patient deaths. Phenotyping alone using uracil, plasma uracil concentration resulted in 36% of false negatives. Looking at the dihydrouracil to uracil ratio resulted in over 20% false negatives. All of these increasing the risk of severe toxicities or patient deaths. But by comparison, the multiparametric test demonstrated less than 5%, 4.7% false negatives. And this fell to 2.5% when looking for grade 5 toxicities alone. The 4.7% and these other data refer to grade 3 to 4 toxicities. So the multiparametric test has been published for over 1,800 patients, and this list of studies is not exhaustive. It consists of a combination, first of all, of the genotyping result for the 4 mutations discussed, with phenotyping using the uracil concentration, dihydrouracil concentration, and the metabolic index described. And these are processed by over 170 mathematical calculations. This data is combined with patient characteristics, physiological, pathophysiological, treatment data, and associated treatments. And all of this data is combined to produce the 5-FUT algorithm. And it's important to state here that Eurofins Biomnis have experience of over 15,000 tests since 2015, and ODPM have experience of, I believe, almost 100,000 patients. So it's a well-established method. So the 4 methods were compared in a study published earlier this year that I referred to earlier. This is entitled A Comparison of the 4 Screening Methods for Detecting Fluoropyrimidine Toxicity Risk. and it sought to identify the most effective and cost-efficient method to save lives. It was published by Capitaine et al. In the Dose Response Journal. In this study, 472 patients with a variety of solid tumours were screened for DPD enzyme deficiency using the 4 methods that I've outlined: genotyping, phenotyping using uracil alone, phenotyping using the ratio, and the multiparametric method. And the results were compared using robust statistical analytical methods. So this is a rather busy slide, but what I'd like to draw your attention to are the comparisons in various statistical properties here on the left for the 4 methods, genotyping and so on. So as mentioned, if you look first of all at false negatives, which of course carries the risk of missing a patient who will not tolerate their fluorouracil. Genotyping for grade 5 toxicities carried a risk of 36%, phenotyping 23%, uracil concentration, phenotyping using the ratio 14%, but the multiparametric method only carried a risk of false negatives of 2.5%. In terms of patient deaths, again, let's look at the false negatives predicted by the various methods. So, genotyping alone showed 51% false negatives. Phenotyping, almost 20%. Phenotyping using uracil. Phenotyping using the ratio, almost 10%. But the multiparametric method, only 2.4%. And we've been through these numbers. So the study concluded that the multiparametric method demonstrated the significantly greatest prediction of performance. And this was highly statistically significant with the p-value in the 3rd place of decimal you can see here. In this study, the multiparametric test would have prevented all but 1 of the 41 patient deaths which occurred. The results of the multiparametric test are presented as either no evidence of DPD deficiency or evidence of partial DPD deficiency with a dose suggestion made. Now, Eurofins Biomnis can also follow this up with a second test, the 5-FUP, and this test calculates the optimum dose of 5-FU, 5-fluorouracil, once a DPD alteration is detected, and either an increase or decrease in dose might be recommended. The increase in dose will be for those patients who were partially resistant, if you like, to 5-fluorouracil, and their resistance would normally go undetected, but the drug they would receive a suboptimal therapeutic dose. I should also say here that several pharmacoeconomic analyses have shown significant financial savings associated with the use of the 5-FU test. And this derives simply from the fact that many toxicities are prevented using the multiparametric test, the 5-FU test. The treatment of these patients, the intensive treatment of patients with severe and very severe toxicities, results in hospitalization and sometimes prolonged periods in ICU, which gives rise to very high expenditures. By preventing these toxicities and hospitalizations, the hospital saves significant sums of money. And this has been shown in several studies in different countries and different settings. So the practicalities involved, we require 3 specimens for the 5-FU test, 1 lithium heparin whole blood refrigerated for the genotyping, and 2 lithium heparin frozen plasma samples for the phenotyping side of the analysis. So if you would like to know more about this study, you can either go to our website email us at either this email address or myself at Eurofins Biomnis. These slides are available should you want them, and they're accompanied by a full bibliography. And thank you for your attention.
Great. Thank you very much, Jamie. We'll be moving on now to our panel discussion portion. My name is Linda Sell. I am the Marketing Director, International Export Director of ODPM. And I'm going to just introduce quickly our panelists. First, Michel Boisdroncel, who is a PharmD PhD, Pharmacology, Toxicology, and Pharmacogenetics, and is the head of the Biopathology Lab at the ICO in Angers. And Andrew Kenny, who is the Chief Medical Scientist, Biochemistry in Bon Secours, Cork. They will be available for answering questions in the Q&A portion, and please feel free to chime in during any part of the panel discussion, both of you. And for the main event, we have Dr. Brian Bird, who is a consultant in medical oncology, possibly well known to some of you in the room, with a specialty in GI cancer, lymphoma, and immunotherapy. And Dr. Jean-Philippe Medjes, who is an oncologist specialized in digestive cancer, also in France, professor at the Cancer and Hematological Institute in Brest. He's the co-president of the French Cancer Meetings, which he will be running off to moderate in a few minutes. So let's get right to it. As you both know, and as you all know, the EMA has recommended recently the DPD testing in Europe. Just this summer, the NCCP in Ireland has recommended testing without specifying which method, while France has chosen the uracil only method. We've seen in the slides why this is not as effective as a test as the multiparametric method that's now done by Eurofins Biomnis. Jean-Philippe, you've been using the multiparametric method for many years now, while Brian's been using it for about a year. Jean-Philippe, can you give us an idea of why you've decided to stay with the multiparametric method, even though France has directed you elsewhere?
Yes, the response is very simple. The best is the more for the patient. When you use a monoparametric test, you have a response for only a part of the problem. The problem is we don't treat dose, we treat patient, and especially with poly treatment. I mean, we had to find a few over treatments, and our patient can have some side effect or can have some drug in addition. So the fact that when you test only with the uracil, only a little part of the profile is, to my point of view, not the best way to have the best in terms of security for the patient. That's why I use, and I still use, and my institution still use the multiparametric approach, due to the fact that in my practice, 5FU alone is a very little part of the patient, and the patient with FOLFIRI, FOLFOX, and other are clearly the part. So that's the way we connect with ODPM, and that's the way we stay with this test.
Great, thank you very much. Brian, you've been using different methods for a decade now. Switch to the multiparametric method once everyone's seen it. Can you give us an idea of your experience with other methods, and what was your thinking in coming towards the multiparametric method at this point?
So when I returned from training in America 13 years ago, my colleague, Dr. Colin Murphy, and I had a series of near fatal events in patients receiving 5FU for colon cancer with prolonged ICU stays. And back then we were doing reactive DPD testing, that after the patient was hospitalized and nearly died, then we looked to see what the genetic reason was. And I think we were scarred by these near-death events. And we were the first hospital in Ireland to move to prophylactic genotyping and checking for DPD. And we certainly managed to avoid grade 5 and most grade 4 toxicities, but we hadn't ruled out grade 3 toxicities. And I think I have a case with a few slides I can show. And so what we're hoping is that when we switch to the multiparametric model with Biomnis, that we will be having fewer grade 3 toxicities where patients are hospitalized and their treatment is delayed and sometimes can never be restarted. I just wanted to ask Michelle, does it matter what the patient eats the day before they have their test taken, and does it matter what time of day they have the test taken?
Michelle, you need to just turn your... Let's see if I can... OK. Est-ce que tu as compris les questions, Michel?
Tu peux la dire en français? Attends, je ne sais pas si j'ai mon micro.
Oui, c'est bon, on t'entend. Excuse me, everyone, I'll just translate it very quickly for Michelle. Brian a demandé si c'est important ce qu'il mange, le patient, le jour du prélèvement, et si c'est important, si c'est le matin ou l'après-midi.
No, I think it's independent in the morning or in the afternoon. No problem. Because you do the report, you issue under you, and it's relatively stable on the day. About alimentation, I have no idea. In fact, we don't do a study about alimentation.
I think that not your test, but the uracil alone test can be affected by a high protein diet or the time of day. But because you check the ratio, hopefully your test will overcome that limitation.
Yes, I think uracil alone is influenced by alimentation, but not the ratio.
It's a good point, Dr. Bird. Thank you very much for that. I just wondered, sort of offhand, what do you both think of the EMA decision? Is it sufficient what they recommend, or would you personally prefer to see them go further?
So I think that I would prefer to see them go further, but it's a big step. And a lot of my colleagues most Irish oncologists are US trained. A lot of my colleagues are skeptical and are concerned about underdosing patients. And I'm having these conversations with them. But there's an acknowledgement that it's now medico-legally negligent not to do some sort of testing, and at the very least to do DPD testing. And that is going to stop 20%, 25% of the serious toxicity, maybe 50, 60% of the life-threatening ICU stays. But I think that as my colleagues get more used to dosing and to gradually increasing the doses post-DPD mutations being detected, then, like me, they'll be hungry for more. They'll want to prevent more toxicity to enable us to give multi-chemotherapy regimens, which Professor Metsch has mentioned.
Great. Jean-Philippe, would you like to add anything to that?
I'm so happy to see that Europe is moving on altogether against one type. Few minutes ago or few hours ago, Norbert Ifra is the head of the Cancer Institute in France. And he showed the next program for fighting cancer for the next 10 years. And one point in this program, this is a French national program, is to fight against side effect of the anti-cancer drug regimen. And this fight has not begun 3 years ago in France, as you know, because for a part we test DPD for more than 3 years. So the fact that altogether we decide to fight against potential side effect or clear side effect for a part of patient, and that we improve the management of the patient in order to treat the patient as a kind of personalization, because we can personalize the treatment by 5FU and other chemotherapeutic regimen, and then add, that's the new fact, the side effect or the potential side effect of immunotherapy is a very good news. Do it all together.
Very good. Thank you very much for that. I wanted to sort of, in that same line, bring our attention to the fact that with the multiparametric method, when you're given the results, if the patient is deemed to be at risk for DPD deficiency, at the bottom of the result page, you will have a suggested dose. And I just wanted to ask both of you in your experience, how often do you use that particular dose? And if you don't, what are the parameters that you look at for modifying that suggested dose that comes from our algorithm?
Alors, je crois que Jean-Philippe a beaucoup plus d'expérience que moi. Alors, à vous, Jean-Philippe.
So, first, as I said previously, we treat the patient. So when we perform a pharmacokinetic for the first dose, and then we have a potential dose for the second treatment, we have to analyze the potential dose and the proposal, but we have to analyze also and give the information to the pharmacologist of the patient. So at any moment for the second dose and over, you can give the right dose because you are a link, the oncologist, between the pharmacologist approach and the patient approach. That's the first point. The second point is the fact that it's a pity what I'm going to say, but it's true. In prospective trial, I don't mean about 5FU and DPD deficiency, I mean about prospective trial, for example, for esophageal cancer or gastric cancer, where we have a very poor prognostic. We have in any trials, the fact that non-DPD deficiency till 10, 20 years. How many people respond no? But in fact, they don't know because they don't test.
Right.
And now we are able to test. And probably, you remember that French people are a part of love with revolution. We have to move to, in this trial, able to be, to give and to enter patient with this kind of profile of DPD deficiency, not a total DPD deficiency, but a partial DPD deficiency, because actually they are not involved. Because when we say to the PI or the top of the structure in the worldwide study, they say, oh no, we are not able to change the dose. So I try to say that it's strategic to discuss about the dose the pharmacologist give when you see the patient at the same time. So yes, we can use the dose, and usually we respect strictly the dose for the first infusion and the proposal. And then when we perform pharmacokinetic approach, we have this discussion. So that's the way, and that's the way to be better for the patient.
Great, thank you. Dr. Burt, do you have anything to add to that?
So I think that Jean-Philippe's point that we should be able to recruit patients with partial DPD deficiency to clinical trials, and currently they can be excluded. And normally the 5-fluorouracil is the most boring part of the trial.
Right.
The more exciting drugs we're adding in on top, but we can't get the patient with a DPD deficiency on trial And in our population, about 11% of patients have some DPD deficiency. But we normally will have time to order the first dose as recommended by Biomnis.
We do.
But in Ireland, a lot of hospitals buy in the 46-hour infusers, and these are banded to the nearest 250, the nearest 500 milligrams. It's a national strategy. So I think that we'll have to decide whether we go for a banded pump that's close enough to the recommended dose, or whether we will delay treatment to get in the exact amount recommended by Biomnis. Now, I think that those restrictions aren't as important in France, but they are very real in Ireland.
Right, that is definitely a difference. And Jean-Philippe has been talking about a second part of the test that we provide to Biomnis here at ODPM. It's called ODPM protocol, and that is the therapeutic pharmacokinetic guided dose adjustment throughout the cycles of treatment. So before the first treatment, the physicians will order the 5-FU-T or the ODPM tox. And then during the first cycle, the second cycle, and maybe even the third, depending on the parameters, they'll order another blood test. And we just didn't have time to include it in this webinar, but we are certainly available to discuss that further. Sorry?
So are there questions from the audience? Because my case covers some of the points you made about the two tests.
Great. We'll get to that right after, since we have a little bit of extra time, since Jean-Philippe doesn't have to leave. I just wanted to bring Andrew Kenny in, who is the lab manager at Bon Secours. And I wondered if you could give us a little bit of your experience technically with the test and what your appreciations are of it today. There we go.
Yes. Hello, everybody. Basically, we have been involved with sending samples for Dr. Bird since about June of last year. We've sent 11 of the 5-FU-Ts. We've sent 4 5-FU-EN, which would be the drug dosage, and we sent 1 5-FU-P this year. So that's our experience with it thus far. Sample types, but primarily our experience is trying to get all the information up front. Specifically, there is a form that needs to be filled, and it needs to be filled in its totality. All sections need to be filled, and also there is a consent form at the back as well that needs to be filled as well. And we found that any deviation from the total filling caused a delay in the actual processing of the samples. So that is one thing. Also, the fact that the samples need to be drawn, and specifically for the uracil dihydrouracil assay, it needs to be spun at a specific centrifugation speed and time, and separated within 1 hour and frozen. So there are constraints within the processing of the samples, but once you actually adhere to those to the letter and have the proper form prepared, it works out fine. The reports coming back are quite complicated. There are quite a lot of text in them, but we now have list-to-list laboratory information system to laboratory information system. So only in recent times, in the last couple of months, we have that set up so that the entire report is coming directly into our patient file. That reduces any probability or possibility of transcription errors in the middle. So that's our experience thus far, and we are planning to move to this in the short term to a more extensive usage of the test.
It's great. Thank you very much. And just wanted to thank, in front of everyone, both your lab and your team and the Biomnis team for working so hard and diligently to get to a point where we don't have the same difficulties and errors that we might have experienced in the beginning with the forms not being filled out. Jamie, I just wanted to bring you in here for a second. You've come up with a really good idea for a single point of contact for each hospital.
Yes. So as Andrew has alluded to, errors in filling out the form or preparing the samples will result in delays to us giving the result back to the clinic, which of course can give rise to lots of problems. So our suggestion is that each oncology centre nominate 1 or 2 people who are responsible for filling out the forms or overseeing the sample preparation, either at the ward level or in phlebotomy. And this way they'll be familiar with the process, they can do it quickly and cleanly, and will avoid the errors that can arise and cause complications, just to nominate 1 or 2 people for the process.
Okay. I have a very last question before we move on for the panel, before we move on to any questions from the attendees, which for the time being, I don't see any. So this would be the time, if anyone has questions, to prepare them and send them in the chat room. Brian, Jean-Philippe, I'm sure you can answer this question, but I'm going to send this over to Brian. I know that you've done a lot of work on the economic impact of this test. And I wondered if you wanted to just make a quick statement. We just have a few minutes left on this side.
Yeah, so we estimate and that for every patient who's hospitalized with 5-FU toxicity, the average stay is around 10 days. And the cost in the public sector is at least €30,000. But if the patient is admitted to intensive care, maybe as high as €100,000. So if we're even preventing 1 hospitalization, we pretty much have broken even as a healthcare system. So I think that it's very cost effective, because if 1 grade 3 toxicity costs €30,000 and a grade 4 toxicity can cost €100,000, it makes a lot of sense. Now, the difficulty is getting the government or the insurance company to see it like that and pay for it.
Right. Well, that's what we're here for. We've been working on it for years, and we'll keep working on it until it gets to the point where the governments understand what we've been saying for so long. So I thought we had a question, but we don't seem to. Kirsten, you can let me know if that's the case. I see someone is just, okay, I see we have one question. Kirsten, I'm just picking it up from here. The question is, from the laboratory point of view, once frozen, how stable are the samples and what is the turnaround time? So I think we can answer that. Michelle, would you like to answer that question? How stable are the frozen samples first? Oh, we're getting some interference. Well, the samples are very stable, frozen. I'm not sure whose echo that is. Sorry about that. The frozen samples are quite stable. It's at least 30 days, if not more, frozen. And the turnaround time for the test is 10 days. Let's see, another question. Oh, well, turnaround time. It was on turnaround time. So while other people may be organizing their questions, we do have time for Dr. Bird's presentation, which is a case study of one of his patients. So, Kirsten, if you want it, there we go.
Thanks very much. This is a paper which my colleague and I published looking at our experience of DPD testing. And I think Jamie did an excellent job talking about the complicated metabolism of 5-fluorouracil and of the prodrug capecitabine. And one of the enzymes involved in converting capecitabine to active drug is cytidine deaminase. But we found that in the Irish healthcare setting that it was cost effective to do DPD testing, but that it would only prevent around a quarter of toxicity. Next slide, please. Oh, actually, I can do that. Great. No. I'll do it. It's okay. I'll do it. Yeah. So I'd like you to imagine what you would do in your hospital with this man. He's got 75, he's got Crohn's and a history of coronary artery disease, but he's fit and he's playing golf. And he comes in with an unresectable pancreatic cancer. I put the blue arrow on. It wasn't the blue arrow on the patient when he walked in. And we did the pharmacogenomics, and his DPYD was wild type. So he didn't have any mutations in DPYD. And after discussion, despite his age, we decided to give him FOLFIRINOX. And he was admitted with life-threatening diarrhea, stomatitis. And you can see here that his bowel wall is thickened and edematous. And his neutrophil count was less than 1. And he was febrile and in a lot of pain. And he required 10 days in hospital with intravenous fluids and intravenous antibiotics. Now, he did not require transfer to critical care for inotropes. And we found that he had a cytidine deaminase mutation. And then we used the 5FU level service from Biomnis to guide our subsequent therapy, which he did tolerate very well after a delay of a month before he was well enough to go back on treatment. So various doctors who worked with us have looked at our smaller data, but 11% of our population who are screened prophylactically have a DPYD polymorphism. But of the 34 patients who were DPD wild type admitted with 5FU toxicity, 21 had a CDA mutation. Whether or not they were on 5FU infusions or capecitabine. But there's lots of patients with a CDA mutation who have no toxicity. So we can't use CDA to dose 5FU. And I think this comes back to the benefits of measuring the dihydrouracil to uracil ratio and using the multiparametric model. And I think about it, it's a snapshot of the ratio of dihydrouracil to uracil. And it's a very good insight into how the patient is going to handle 5FU and to safely pick the initial dose of 5-fluorouracil. And I think that this case shows that just doing DPD is not enough. That's it. Thank you. Can we go back to the conference screen?
Okay, sorry, I'm not sure. Can you hear me now? Yes, probably. Kirsten, can we go back to the conference screen, please? No, I was saying thank you for the idea of it as a snapshot, because I've been thinking of it for years as a reflection, which is more like a mirror image, but it is true. It's the UH2 over U is very much a snapshot. It's a good image. So I think we have one more question that has come through. Jean-Philippe, did you have a reaction to Brian's presentation?
Yeah, the colleague point the fact that we treat patients with poly regimen, and so the fact that we have a multiparametric approach is very important. And he point also the fact that they have a discussion to use the FOLFIRINOX regimen for a pancreatic cancer in a patient just 75. In the literature, in fact, the first paper with the FOLFIRINOX regimen in pancreatic cancer was in JCO, and it's true that the 75 cut in terms of profile of patient, 75 years, was very efficient, and I think it's still good. The fact that you have a multiparametric approach, put in the same box the genotype, the phenotype, and the profile of the patient, and the addition of drug. And that's, to my point of view, and you say that, the point. Because you can have in addition of DPD deficiency or partial DPD deficiency, a profile of toxicity with irinotecan also. Mm-hmm. And so if you connect all, you can have probably the good treatment to do. And when I speak about the first proposal, we always use the first dose as a proposal. The only point is, if you want to have a very good administration in the second, third, and fourth line, you can add pharmacokinetic approach. But the best way is, due to the fact that you have a proposal of the 5FU in connection of the genotype, the phenotype, and the profile of the patient, and perhaps the drug intake, the other drug intake, then you have a proposal. And in my habit, we always use this proposal.
Okay, great. Thank you very much for that. Because it was part of my question.
It's essential to understand that due to this multi-parametric approach, we have the good dose for the patient.
Right. So the confidence that you have in the algorithm, in the calculation that's done, is quite high. I'm hearing because the question that I had was, at what point would you, even for the first dose, you're clearly looking at the patient's state, because the blood work would have been done 10 days, a week to 10 days before. So things could happen in the meantime.
Yeah,
but
that's true. That's true. In case of a change in the health status of the patient, we are not in a strategy to use the test for the patient 10 years ago. No, we can clearly discuss. But for the point, really, Hadget people are an important part of our patient. And when I was fellow Hadget people, the question was, do we treat? For now, we treat with G8 status for geriatric parameters, but also to give the right dose to the right patient. And that's the point.
Very right. Exactly. Thank you very much. I think we might have lost Brian, I'm sorry to say.
Yeah, looks like it.
Let's see, we had another suggestion. Oh, there's Brian. Great. Welcome back, Brian.
Thank you. Sorry, I don't know what happened to the internet.
Yeah. Okay. So there's a suggestion from one of the attendees who was suggesting that a pre-analytical audit for the DPD test would solve some of the issues at sample collection, which is true. And for any new center that's going to be putting this in place, Biomnis does work with every center to be sure that their sample collection is in line with our parameters. So there's really no issue there. We work with it. I'm not sure where that's coming from. Let's see if we can continue. Dr. Bird presents his own question. Thank you. What percentage of patients have high baseline DPD activity and need a higher dose? Well, I had prepared some slides for that, but we didn't really have time for them. In 2008, in Journal of Clinical Oncology, our team with Dr. Gamlin et al. Suggested that 40% of all patients are high metabolizers, so need additional dosing for the following cure and the following cycle, and so on. So we're talking about a potential of 60% of patients who are not properly dosed, the 20% that we've discussed being the slow metabolizers, having a low DPD activity, but there definitely are many, many patients, around 40% in our experience, who are fast metabolizers, which just goes to show you that the standard body surface area dosing does not work. It is not commensurate with the proper dosing of 5FU. Does that answer your question, Dr. Bird? I'm
afraid that the fire alarm went off. I'm beginning to think that there's a sabotage effort against me participating in the last 5 minutes of this call. Jean-Philippe, how often in somebody who's got normal DPD and a high dihydrouracil to uracil ratio, how often do you increase up the doses? How hungry are you to increase up the 5FU dose?
Alors, my response is a kind of joke. I include many patients in prospective study in association with immunotherapy and 5FU and cisplatinum or other. And you know that in prospective trial, we can do that. But if we look to practice, I want one of the co-author of the FOLFIRI-CETUX adaptation of dose. And you see that in FOLFIRI-CETUX, the paper we speak about with Linda and Michelle, we both increase or decrease 5FU and irinotecan, because on the same part, you can have a decrease for Guilbert syndrome. So due to the fact that we have multiparametric approach and that we have poly regimen in terms of poly chemotherapy, we used to do that. And remember that we can do that when we use a FOLFOX regimen, because you have 7 types of FOLFOX regimen with different dose. The way we can improve is the fact that in the profile of patient, when you have the profile before, you can choose between the FOLFOX, for example, regimen due to the profile of the patient. So we do that. And when I speak about personalization of the treatment, that's the way. Yes, we do.
Okay.
But to my point of view, it's the second step. The first point we have to stress to colleague, do the DPD test, because it's very important for your patient. And then clearly we can have an adaptation of the treatment due to the fact that we found a potential proportion of patients who need an increase. But at the beginning, the very important message is test the patient.
Great. Well, we're coming up to the end of our time together. If anyone has a final word they'd like to offer us.
Yes, on behalf of Eurofins Biomnis, thank you everybody for your participation, and I hope the audience found that useful and helpful.
Great. Well, in my turn, I would like to say thank you to everyone for your participation and for all of the really great information that was provided. I will add the article that Jean-Philippe was just talking about in Seminars on Oncology 2017. I'll add that to a bibliography list that will be included if anyone requests the slides, in case you're interested. So thank you very much, Kirsten.
Thank you, everyone.
Merci. Au revoir.
Thank you so much.
Au revoir.
Thank you. Bye-bye.
And I hope to see you soon.
I hope so, Michelle.